Hello everybody. So today we'll be reading about early pregnancy complications, which was part of the 4 subtopics, and we will be reading about pregnancy of unknown locations. So this is a very important topic because pregnancy of unknown location as such is not a diagnosis. PUL has to reach to a certain diagnosis. Either it becomes a intrauterine pregnancy, or it becomes an ectopic pregnancy, or it becomes a failed pregnancy, or it remains as a PPUL, which is a persistent pregnancy of unknown location. So let us see and understand how to approach this PUL. So let us see about pregnancy of unknown location. The incidence of PUL is as high as 8 to 10%, and I'll also give you the reference. This comes from BJOG, which is 2011 data. So let us see what is the investigation of choice to understand or to approach a pregnancy of unknown location. It is transvaginal sonography to rule out any kind of ectopic pregnancy where the sensitivity and specificity of this modality is as high as 87 to 94% and 94 to 99%. Please understand, if we are approaching a pregnancy of unknown location, here TBS plus a transabdominal sonography both together becomes mandatory. You have to perform a transabdominal sonography, only then your investigation will be considered as complete along with the blood biochemical markers. So remember, always supplement a transvaginal sonography with a transabdominal sonography. Once a UPT is positive, that means beta-HCG is positive, there can be following 5 possibilities of pregnancy. One is a defined ectopic pregnancy. Second is a probable ectopic pregnancy. Third is a pregnancy of unknown location. Fourth is a probable intrauterine pregnancy, and fifth is a defined intrauterine pregnancy. So these are, once you know that the UPT of a patient is positive, you can have only these 5 possibilities here. Let us understand each one of them separately. First, let us come to a defined ectopic pregnancy. What is a definitive ectopic pregnancy? Where you know that there is an extra uterine G-sac along with the yolk sac, with or without fetal pole. So you have seen that there is an extra uterine G-sac, but yolk sac may or may not be present, fetal pole may or may not be present. You're sure that this is a definitive ectopic pregnancy. Second, how do you say that it is a probable ectopic pregnancy? What is the defining criteria for that? It is a heterogeneous adnexal mass or G-sac like structure in the adnexa. It is a heterogeneous mass which can mimic a G-sac, but you're not sure whether it is an extrauterine G-sac, so that becomes a probable ectopic pregnancy. Third is probability is a pregnancy of unknown location, where you do not see an intrauterine pregnancy is not visible, ectopic pregnancy is not visible, you think that it could be a pregnancy of unknown location. Fourth is a probable intrauterine pregnancy, where there is an intrauterine echogenic G-sac like structure. And the last possibility is that it could be a definitive intrauterine pregnancy, where there is an intrauterine G-sac along with a yolk sac, with or without fetal pole. So once you see that the intrauterine G-sac is present, there is a yolk sac, you know it is a definitive intrauterine pregnancy. It could be a failing intrauterine pregnancy, fetal pole or fetal cardiac activity does not appear. So now coming to pregnancy of unknown location. So these were the 5 possibilities when the beta-HCG is positive or a UPT is positive. Now coming to PUL, a pregnancy of unknown location. This is, remember, it is not a final diagnosis. It can have following 3 or 4 possibilities. Either it can become an intrauterine pregnancy, That is 30 to 47% of PUL are ultimately intrauterine pregnancy. They can be either viable intrauterine pregnancies or they can be non-viable intrauterine pregnancies. But it is an intrauterine pregnancy, is the final outcome of that PUL. Second possibility is a failed PUL, failed pregnancy of unknown location, which can be encountered in 50 to 70% of the cases. Third possibility is that of an ectopic pregnancy, which is present in 6 to 20% of the cases. And last final is a persistent PUL, where you actually could not identify the GSAC and you could not make it out. This is just 2%, which is called as, should be called as PPUL, but for convenience, ease of use, it is called as PUL. So these are the outcomes of a pregnancy of unknown location. Now let us see PPUL or PULP is not a final diagnosis again. So PUL is also not a final diagnosis. PPUL or PULP is also not a final diagnosis. Its outcome depends upon ectopic pregnancy not visualized. So there was an ectopic, but we could not visualize it because the beta-HCG either did not cross the discriminatory zone or the sensitivity of the radiographer was not that great. So there was an ectopic pregnancy which was missed, or it could be a treated PPUL. Third possibility is it could be a resolved PPUL. Fourth is a histological intrauterine pregnancy. So these are the final possibilities that can happen with the PPUL. First we studied about UPT being having certain differential diagnosis, then we studied about PUL having certain outcomes, and PPUL having certain final 4 possibilities or outcomes. Now let us understand the role of biochemical markers. Role of biochemical markers. First is HCG or beta-HCG. It should be above the discriminatory zone. You all understand what is discriminatory zone? Discriminatory zone is the minimum value of beta-HCG which should be positive so that the pregnancy is visualized on an ultrasound. It is usually 1500 to 2000 international units per liter. Second is a role of progesterone. And there are few other biomarkers. I will be naming certain important biomarkers which are under study. Some of these being 1. Creatine kinase, CA125. That is why CA125 is not used as a tumor marker during pregnancy because it is otherwise also raised in pregnancy. Third being inhibin A. Then is inhibin pro-alpha C related immunoreactivity. The other one being IGF-BP. What is IGF-BP? It is insulin-like growth factor binding protein. So out of these, the most promising one is inhibin A. This can be one of the viva or your OSCE question. So please remember, it is a newer development where inhibin A has some role in identifying and prognosticating or managing of PULs.